Moving on, ladies and gentlemen, item 1, attendances. I gather we have apologies from Councillor Mrs Weston and Councillor Bennett. Any others, Alex, that we've received?
None others received.
Thank you. Item 2, the minutes of the previous meeting. Has everybody had sight of these in the to follow report? Is everybody content that they're a true and correct record? Super. Can we move they're accepted then? Item 3, declarations of interest. Shall we do the usual round robin just for clarity? Let's start with Councillor Tate.
As previously, I work in the National Health Service, not in Trafford, in Merseyside.
I work in the National Health Service as well, but the organisation is now Airedale Foundation Trust from the previous minutes.
Much. Item 4, then moving on, questions submitted by the public. I have been advised that there aren't any at this particular meeting. Item 5 then is, we will take these slightly out of order. We will do item 6 before item 5, if that's all right with the committee. So we will move straight on to Trafford Coordination Centre, page 15. So I gather we have a report to come to us.
Thanks very much. My name's Cathy O'Driscoll. I'm the Associate Director of Commissioning at Trafford CCG. So thanks very much for inviting us to give the update on TCC today. Oh. Sorry. Getting used to the technology. So as the Trafford Coordination Centre has evolved, so have the objectives of what we're trying to deliver. So the core foundations of when the service was commissioned still remain. However, as we've evolved as both the health economy, so have the objectives within them. So one of the key bits being to improve the health and well-being of people experiencing physical or mental health difficulties. The key bit being through coordination of medical and non-medical interventions to support people live well and age well at home. I'm not going to go through them all, you can read them there, but hopefully the rest of the presentation will explain exactly how we deliver that. So this is a summary of where we're up to. This is the review for 2018, and I wanted to demonstrate some of the really innovative work that's being delivered through the Coordination Centre and how it's become really the bedrock up for Trafford, and how we receive our referrals, how we manage patients, and really the IT infrastructure that's supporting that to ensure that we get the most out of our healthcare system. So firstly, care coordination, and I'll go on later in the presentation to actually define what that is, because it can have a number of assumptions by different people. So we've got over 2,000 patients that are enrolled in care coordination. They've received over 4,000 interventions, but some of the key bits that I wanted to highlight today is firstly the 300 and odd patients that are being supported on the falls pathway. So this is a new service that we deliver. So these are patients who are have either been admitted into hospital through a fall or have been referred in by their GP following the falls protocol. So for those patients that are enrolled in the Care Coordination Centre, they are dealt with by the clinical team, and they contact the patients and they offer them a number of different assessments to hopefully prevent them from going into hospital again. These include things including the home hazard assessment, the vision assessment, medication reviews, strength and balance exercises, and ensure that all those patients that have been identified either having a fall or potential for having a fall receive all of these interventions, which will hopefully prevent them from going in again. We're working very closely with NWAS. So now any patients that are identified as having a fall, so when NWAS actually go out into the home, the patients are then referred directly into the Care Coordination Centre to be supported by the Care Coordination team. We have alerts now, so the integration of the Coordination Centre has really developed over the last couple of years, and in line with the GM interface, we are ahead of the game, as it were. So some of the assessments that have been made about the interventions have really identified that the alerts and information we receive are slightly ahead of the GM strategy. So we now have direct information from A&E, from out of hours. And what that means is that we can identify patients who've been admitted, who are enrolled in care coordination, and support them when they get discharged, or support that discharge process, because we're actually having live feeds of data coming into the centre. We are part of the One Trafford response case briefings. So because we have access to both GP information, out of hours information, A&E, hospital admissions, etc., we're able to give a real raft of information with the One Trafford response and the case briefings, hopefully giving some, and we do give some real depth of information about what's going on with the medical history of that patient, which supports the greater One Trafford response for both social, etc. We've started the Winter Wellness Call programme to all patients who were admitted last winter. So the clinical team contact them. They've got their case history, so they know their medical history, and they give them wellness calls to ensure that they are safe in their own homes, they're being supported, they have the right medical needs and support. One of the big things we're doing this Christmas is the call at Christmas. So the TCC is open 365 days a year. So all patients that have been identified as having conditions or have been identified as being lonely will receive calls on Christmas Day, which will hopefully, and Boxing Day, which will hopefully identify anybody that's potentially the most socially isolated out of our patients. So referral management, this just gives you an indication of the numbers that have gone through the referral management process. So we manage 75% of all of the referrals in Trafford. So the majority of our GPs refer through the coordination centre. And I'll go into a little bit more detail about that as well. So some of the highlights are, it has redirected 1,000 referrals into community services. So these are referrals that have come into the coordination centre and are checked by our clinicians. And where it's deemed appropriate, in coordination and agreement with the GP, they are redirected to the most appropriate services in the community. So rather than patients having to attend secondary care, they're deferred into the community services that will offer them greater access and better choice, and hopefully an earlier appointment time. We've started the diabetes clinical triage, which is now in operation. So all referrals from GPs for diabetes come into the coordination centre, and our clinician refers all of those diabetic referrals and reviews them to ensure that they're clinically appropriate, and then directs them to the most appropriate place. For 2019, we've got lots of other innovations starting, but one of the key ones to note is the smoking cessation pilot. So we've trained all of our clinicians, all of our nurses within TCC, and they are now trained for motivational interview training. So the GPs identify the patients who want to quit smoking, and they are referred into the TCC, where the clinicians will contact them to support them through what can be a quite challenging time when trying to give up smoking. And this falls in line with the respiratory pathway that we're developing, so that what we're trying to do is prevent patients from smoking, so that we know that that attributes to a significant number of health conditions. So we're trying to do the preventative element with the support of the TCC, and giving that support to GP practices who might not necessarily have the time to dedicate to supporting people to stop smoking. It will always be done in conjunction with the GP practice, and feedback will be given, but hopefully the results will show that we'll get some fewer admissions in the future of patients going into hospital with respiratory conditions. One of the other big ones that I think is hopefully will have a significant impact is alerts for carers when they have a hospital admission. So we quite often identify that when a carer goes into hospital, somebody is potentially left at home not being supported, and therefore when the carers go in, we will ensure that the patient, the person that they're caring for, has the right support surrounding them to ensure that they stay well while the carer gets well if they're admitted. And we're working in the partnership with care navigators. So the care navigators will be, their service will be delivered in the acute, but they will support patients to come out of hospital and to ensure that they have the right support network wrapped around them. That could be a number of things, from having the right healthcare support at home, having the right equipment made available for them, and also the social aspects that they might need. If it's been identified that they are slightly lonely, or they've got a particular interest in a knitting club, whatever it is, the care navigators will support them from their admission from hospital into the community, and all that information will be held and supported by the care coordination team, and they will ensure they get everything they need. So hopefully they will remain out of hospital and not be readmitted. So this just gives a summary of what the care coordination basic package of care is. Hopefully this will give you some understanding of what our clinical team do. So patients are identified either from GP practices, from the community enhanced care team, people with high needs. These are patients who've in the past had a number of admissions, so they have quite complex needs. And the clinical team contact them and just go through a series of questions with them and give them that support that hopefully might prompt additional services to be supported with them. They maintain the safe environment. If there's any safeguarding issues, health promotion, social services, care packages, they will contact anybody that they need to ensure, if it's been identified, that the patient has a gap in their care. They form part of the wellness call. So for every patient enrolled in care coordination, they all receive an initial welcome wellness call. They are consented onto the programme, obviously, prior to being contacted by the coordination centre. And when they have that first initial call, what they do is they assess them in regards to what their healthcare needs are and how often they might need those phone calls and that support network. And that's identified on the system, and then regular logs will be taken and the patients will be contacted accordingly. And again, this just highlights the alerts that we receive into the TCC on a daily basis, so from A&E, admission, discharge, outpatients. So if we identify, when the alert comes through that a patient who's part of care coordination has been admitted to hospital, we go into that patient record and look at things like, have they got a district nurse coming to see them in 2 days' time? Or is there anything that we need to cancel on their behalf because they've been admitted? Is there any social circumstances that we might need to be able to support them to ensure that when they're discharged, they can be supported fully and get out on time when they need to? So this is just a pictorial example, so I thought it might be easier to demonstrate in this way. So this is the care coordination service. On the left-hand side, that just gives you a list of where all the referrals come from into the TCC. So GPs, MWAS, OTR is the one Trafford response, the risk stratification process. So we identify patients with the highest cohort of patients who have had admissions into hospital. And one of the key ones is about self-referral. So when patients either hear about the service or through promotional materials, they can self-refer if they believe that there's an identified need and they would like that additional support. The middle section here, that just gives you some of the indication of the figures of the referrals that we received and the number of patients that are in the service. And these are some of the pathways that we support patients with on the right-hand side. And where it's got like COPD condition map, these are all work in progress. So these are all new conditions that we're actually going to be supporting patients with in the coming years. So once again, this is a very busy slide, I know. So along the left-hand side, this gives you an indication of, these are the key service outcomes that were identified for the TCC when it was the first conception of the TCC. So the first line being referral management. So we quality check all the referrals that come into the CCC. So what we're trying to do from that, what the main outcome is meant to be about, is about better utilisation of community services. So when the referrals come in, we're ensuring that the referrals are going to the most appropriate provider. This is not about saving money. This is purely about redirecting patients to the most appropriate person and people or service to deliver their care. And hopefully by that, reduce the number of follow-up appointments and better outcomes for patients in the first time. So we've got a number of patients for care coordination on. They are referred. They are patients with really complex needs. So what we're trying to do through care coordination is ensuring that we've got the right system in place, the right services in place, and the right access to care for those patients, which will hopefully have the outcome of reducing the A&E admissions or unplanned admissions, and more importantly, keeping patients well at home, which is exactly where we want them to be. So patients with COPD, diabetes and frailty. So this is what we class as condition management. So what we're trying to do, I'm supporting through the referral routes and ensuring that the referral routes are appropriate. We have the right services available for those patients and supporting them through the management of the condition through a predefined programme to make a difference. So patients discharged from hospital. So coordination of care to support post-discharge. So hopefully when we're supporting the patients, whether it's through the care navigators, whether it's through care coordination, whether it's actually the discussions between the multidisciplinary teams that we work with through the care coordination service, to hopefully then avoid the readmissions post 28 days. When I go through some of the patient stories, hopefully that'll give you a really good example of those multidisciplinary teams working together and with the support of care coordination team, ensuring that they've got the right services in place to reduce that admission, that readmission. So this just is a pictorial example of some of the alerts that we get and how that works together. So the TECT, so that's the Trafford Enhanced Care Home Team. So we receive daily alerts from the hospitals and also from A&E, all the ones we've described before, and we give that information to the tech team, so they're fully informed about what's happening with patients, and vice versa. We get information back from the tech team. So TCC also give daily updates to the KEC team. So we're able to inform if their patients have been admitted, and they also give us feedback so we can see the data that's available from the KEC team when they've gone out and seen patients. So MFT for the care navigators, so we're able to identify those patients who are waiting for discharge and can be supported in the community. So we can work with those care navigators to ensure that the package of care that patient needs when they come home can be in place to enable them to get home safely and on time. And as we've said before, the One Trafford response. The TCC is fully involved in the One Trafford response, meeting on a weekly basis with the multidisciplinary team to talk about patients, those of high needs, and hopefully giving an insight into additional information available so that they can have a rounded view and get the best outcome for those patients. So now we move on to referral management. The top lines just give you an overview of the referrals that are clinically triaged in the coordination centre. So the EUR policies, I'm sure you all know, but just in case not, that's the effective use of resources policy. So that's across GM. And what we do with these policies is all the referrals that come through, make sure they are clinically appropriate in line with the EUR policy. And those that aren't get redirected back to the GP with some feedback and comments to ensure that the referrals are appropriate. Going through the EUR policies, make sure that the referrals, again, are going to the right place, into the right, whether that's secondary care or the community, and ensuring that patient's journey is streamlined and smooth rather than delays being put in the system. And the clinical pathways, these are a number of clinical pathways that have been developed in conjunction with both secondary care clinicians and also our GP community to ensure that for all these clinical pathways, the best clinical pathways available for patients based on clinical need. And these will evolve over time. So when we've done a clinical pathway, it's been reviewed, it's been in process for a number of years, then we review them again and then also see what the key priority are. So when we get feedback from our secondary care colleagues in regards to inappropriate referrals, we'll look at those clinical pathways and hopefully redesign them to ensure that the most appropriate patients are going to the most appropriate services based on that feedback. So these are the 5 key benefits that we look when we're measuring the success and the accountability and delivery of successful services through the TCC. So these are the benefits that we measure. I don't think I need to really describe any of those, but it's just giving you an outline of what they are. So I just thought we'd pick up 2 case studies. So these 2 case studies are actually on here, not because they've had a number of admissions and then those admissions have been reduced as a consequence of the care coordination interventions. But it gives you an outline of just some of the really complex high needs patients that the coordination team actually deal with on a daily basis, and goes through some of the really detailed multidisciplinary input that is required to support the patients with the highest needs. So for both of these cases, the number of admissions actually increased, but that's not a reflection on the support that they were having in the community. This is a reflection of these are high intensity needs patients. And this just gives an example of some of the interventions that was delivered by the TCC, just to give you an outline of the types of patients that we're dealing with on a daily basis. One of the key elements for care coordination is contact versus interventions. And the clinical team are monitored on a daily basis about making every call count. So what's meant to happen is that the number of patients that are enrolled onto the service, which is the blue markers that you can see, for every single one of those patients, they have wellness calls attributed to them or calls on a daily basis based on their risk stratification and their need. And as you can see, over the period of this year, we're now nearly on an equal footing with the number of patients on the service and the amount of interventions and wellness calls that we receive. We receive a lot of calls also from families and friends, and they also give us additional information that we add into those clinical systems. So obviously it's our intention in the next couple of months to have achieved a level playing field in regards to the number of patients enrolled on the service and the amount of interventions we're doing on a daily basis. This just gives a further breakdown. I know it's very small, the writing at the bottom. So this just gives a breakdown of the types of interventions, whether that's advice, whether that's expediting an outpatient appointment on the request of the patient or based on clinical need, whether they book transport, case reviews, referred into the community enhanced care team. It just gives you a breakdown really of the different types of interventions that are carried out by the coordination centre. Just a summary of some of the other benefits. So we've had over 35,000 referrals processed in the last 12 months. Over 5,000 referrals checked against the clinical pathway. And because the TCC actually deal with all of the majority of the referrals for Trafford, the GP time saved has been worked out on a rough estimation of the time it takes in the previous process, whereby the GPs would make all the referrals themselves, they'd check against EUR policies, they do all the administrative type functions that go with referrals. So hopefully, as you can see there, it saves some considerable amount of GP time, which hopefully will have improved patient GP satisfaction. And we also do a lot of patient experience and sampling to make sure that the patients that are enrolled on the service or have been referred through for a procedure in secondary care. So we take great weight in assessing what our patients think of the service. And as you can see from here, 86% of the patients felt that the nurse telephone service is making a difference in keeping them well at home. So in regards to what that looks like in the numbers, there was over 750 patients who were consulted as part of that service. So I think the percentage of pleased patients is extremely good from that survey result. This is just a couple of notes that we've had in. So I thought this would be really, well, I think it's really good. And I know that the clinical team in the TCC are really moved when they received cards from their patients. This was one of the patients who had been diagnosed with cancer and was really struggling at home. And this is one of the cards that they received. And I'm sure when you read through this, and certainly for the clinical team, this actually makes it all worthwhile and shows them really what a valued job they're doing. So these are our immediate priorities. So we're looking to enable COPD, diabetes and smoking cessation pathways. They're the key priorities for the coming months. Now, they've been identified because these are some of the key areas in which we have the highest number of admissions into hospital, especially working with COPD and the smoking cessation to support the respiratory pathways, two key areas in which we know we can really make a difference with the prevention element. So these pathways are being developed, being supported and coordinated through and with our GP colleagues, but also with our secondary care colleagues. They're fundamental in those pathway redesigns. So we're working with them closely on delivering those. Operationalise the remaining alerts. So the only alerts that we don't currently receive is from our social services colleagues. That will come into implementation in January of this year. So for when we look at when the clinical team look at the patients who are enrolled in care coordination, they'll be able to see every single aspect of services that might be supporting those patients. So they'll have social services, they'll have out of hours, they'll have GPs, and they'll also have secondary care, which will make us in a key position to make informed decisions about those patients. More and more case studies. We want to look at a number of case studies for patients and making sure that all the elements are fitting into the service as we want them to, but also if there's any gaps in the service provision that we deliver, so we can make sure that loop is fully closed. Lots of benefits analysis. We need to do much more in actually trying to provide the data and the evidence to support both the cash benefits for actually having the TCC, but other wider benefits, so the system-wide benefits of having this service in operation. And we're working closely with all of our partners to ensure that we deliver those quite quickly. Quality referrals into the service. So we're working closely with all of our primary care colleagues to ensure that as part of the primary care strategy and the quality and outcomes framework, we build in lots of measures in which we can support quality referrals coming in, so there's no delays in patients being referred to the most appropriate place. So analytics as well. So we all know that trying to get some analytics into services and doing that analysis, it's taken a little bit longer than we would have liked, but we're hopeful in the next 6 months that we'll have a full analytics suite to be able to come back and hopefully present to you to share that information. And social care and GM integration. We're working really closely with our social care colleagues in developing all aspects of the services that we deliver. We believe that working together as part of our integration, the CCG and the council fully integrating, that we'll be in a much better position to ensure that we offer really holistic, supportive, both social and healthcare services for all of our residents and patients. And one of the key things that I think, well, I certainly believe in the last 12 months, that the Coordination Centre has really become the key enabler for many of the key priorities for the CCG. So firstly, for financial recovery, due to the position the CCG is currently in financially, the TCC has been a fundamental part of those financial recovery plans. So we've delivered savings through effective use of the EUR policies, through monitoring, and actually delivering some key services through the TCC to refer patients to the most appropriate place, whether that's in the community or in secondary care, and working with our clinicians to ensure that those clinical pathways are actually delivering as they should be for patients, but ensuring that they go to the most appropriate place. And also moving forward, the vision is for the TCC to be the foundation of where everything for Trafford goes centrally through one place, so that with that IT infrastructure that supports it, and with the contact centre being based in Trafford, patients knowing that the TCC will support them not only for their healthcare needs, but anything they might need from social needs, and also ensuring that they've got the right support in their own homes or wherever they may be in a nursing home. And we also will be supporting primary care at scale. So we're working really closely with our primary care colleagues. So in developing the primary care strategy, the majority of which obviously will be fundamentally led through the Trafford Coordination Centre, of which the GPs obviously will have the input into that. But we're going to use the TCC as the bedrock to support all of the key elements that we're trying to deliver for primary care at scale. So supporting our neighbourhood models so that the referrals are going into the community. So when we know in our neighbourhoods we've got a diabetes service, or we've got a respiratory service, or we've got a stop smoking service, ensuring that as the referrals will go through TCC, they'll go through to the most appropriate primary care hubs, and patients will receive the healthcare when and where they need it. And stakeholder engagement. So we want to engage a lot more with our stakeholders to ensure that they really know and understand what the TCC does, what we deliver, and also to get their involvement, engagement about how we can actually deliver the service and develop it even further. Because there will be elements, obviously, that we might not be aware of, that they want to have an input into. So stakeholder engagement is one of the key things on the agenda. So over to any questions.
Thank you very much. I think Angela indicated first.
Yeah, thank you. Just a couple of things. To just look at case history too. What you were saying, this patient had an indwelling catheter and recurring sepsis history. Surely she was under and you referred them to the district nurses and GP, but surely they should have been having district nurse visits anyway, and the GP should have been aware of this lady's condition.
Yeah, the GPs will have been aware of them, yeah. But in regards to the referral to district nurses services, what the TCC do, well, they'll contact the patient because they've given their consent to be contacted, and then the TCC would have also contacted the district nursing services to ensure that that patient was made aware to them, and also for the GP. So it's a double checking process to ensure that that's in place, and also vice versa, so that if there's any information that the district nurses might need from the TCC, based on the wealth of information that they can have that two-way conversation to ensure the patient's safe and well.
Follow on with, also we had a report, let me just get to the page and find where it is. It's discharge. Though it was said a couple of, in this year, discharge from A&E and then discharge from hospital. Is it working better because the connection between Wythenshawe and the TCC? Because at one point at the beginning of this year, I think there was some problems that they weren't being discharged. Has this been cleared up or properly, or not discharged to you?
There's excellent working relationships between ourselves and Wythenshawe with our colleagues there, and with that close contact that we've been having in regards to the referrals, processes and support, the interventions through the care coordination and also the care navigation team have ensured that patients have a smoother discharge and are more supported when they actually get home as well, because they've got everything in place that they might need to have. Yes, it is much better. Yeah, there's still developments for the future. I'm not saying we've fixed the problem by any means, but we are through the close working that we've got with them now. It's delivered significant benefits for patients over the last few months.
Just the last thing I wanted was only 3 things. You talking about diabetes. How is that working? I mean, what diabetic patients under the care, primary care?
Angela, can you use your mic, please?
Right, I thought it was on. Yeah, so how do you work with the diabetic patients?
Yes.
Yeah.
So
Okay.
the referral comes in from the GP. So they're still under the care of their own GP. The referrals all come through the Care Coordination Centre. And our clinician, Dr. Markey, is a diabetes specialist, and therefore he reviews all of those referrals that are coming in. So the purpose of doing this is making sure that the referrals are appropriate and the patients go on to the most appropriate place. But also, if the referrals come in and there's a query about anything, then Dr. Markey will get in contact with the GP who's referred and actually work with them on an education piece to ensure that those referrals in the future will be more appropriate if there's any issues with them. So they still retain under the management of the GP, but it's an additional layer that's put in because we're having a number of inappropriate diabetic referrals, or patients not going to the most appropriate place, or patients who are frequently attending in the acutes as a consequence of diabetic issues.
Jane.
Okay, first, I think it's great that you call patients on Christmas Day and Boxing Day. That sounds like a useful thing. My question follows on quite a lot from Angela's third question, because I wanted a bit more detail on what the immediate priority for the diabetes patients, because I didn't get any picture as to what exactly the services that are available for them, because I'd imagine there's quite high numbers of people with diabetes, probably type 1s and type 2s.
Yeah.
And you referred to educational programs. I mean, I'm aware that most people with diabetes benefit from educational programs, but I haven't got a picture from the TCT, so what they are. I'm just picking up on a few points in the report. So the bit that I wanted to look at was when you said the clinical pathways, and then on the next page there was, let me find the right page. It says management of condition through a predefined program proven to make a difference, and that's reduction in complications. But I didn't get a picture of what that program was, because I'm not aware that there are that many structured education programs available for people in Trafford. So I'm wondering, you've made that an immediate priority. What are the programs? Because it's when you talk about people who are frequent attenders of hospital appointments and things, that's a large number of people that if you intervene early, you can make a real difference.
Yes.
So I wanted a bit more detail to add to Angela's question there. And the second question is just about where people with learning disabilities and other types of disability fit into the picture, because they're going to have a lot of the time a lot more complex needs, and I couldn't see anything in the programme that you offer that takes into account the needs of people with learning disabilities and other types of disability that might have extra needs.
So to answer your first question in regards to diabetes, so the pilot only started 4 weeks ago. The purpose of the pilot is to identify if there's any gaps in services, and it's more about the capability of the GPs who are actually referring into the service and ensuring that they have the appropriate knowledge and referral routes available to them. So the education piece is more about going back to the GPs and see if there's any gaps in the knowledge of the GPs that are referring in. But as part of the wider primary care strategy, we are identifying, based on the volumes of patients that are going into secondary care, we are looking at, as part of that, part of the primary care strategy, about where in Trafford we need to be offering those local services. So in the neighbourhoods, in the GP hubs, we will be offering specialist diabetes services to the local community, either in their own GP practice or a neighbouring practice that will support them. So unfortunately, these are only in their infancy at the moment, so I can't really go into lots of detail, but at the same time as supporting our GP colleagues, and also having better access for patients in the community, we'll be also supporting that with a patient education programme. So as well as delivering those services in the community in the hubs, we'll follow that up with education and support for patients at the same time. So they'll have access to both the preventative element and also the care in the most appropriate place, either being in secondary or in primary care. So unfortunately, they're still in their infancy at the moment, and are currently being developed as we speak. So the purpose of the referrals into the Care Coordination Centre is purely about, at the moment, assessing the referrals from a GP element, so that we can see how effective and appropriate that they are.
Second question was about learning disabilities and people with other types of disability.
Yeah, so the TCC, because it's actually based within Crossgate House, the access for patients is normally obviously over the telephone, so it's not a face-to-face facility in which we actually treat patients face-to-face. So all of the appropriate mechanisms are in place in regards to loop line. We have identification through the system in where they have specific healthcare either or learning difficulties if they're identified to us. So in the GP notes, we'll be able to identify at that point that somebody might have learning disabilities. So therefore, they will be treated in the appropriate manner to ensure that they get the right services and access to the TCC.
So just my final point is, I'm hearing from you that you've identified gaps in services for both those groups that were mentioned. So perhaps we can hear about what you're going to be doing sort of to plan for services, because that was something part of the presentation that you're looking at. Well, this is what people need.
Yeah.
This might be the gap in service in Trafford. So for both those groups, it does sound like there's kind of looking at nice guidelines and things, that there are significant things that aren't being offered in Trafford at the moment. So I guess my question is, when you are identifying those gaps, where are they going to address them?
Yeah, so it's about the main thing that we want to offer is about equality and equity to access to services. So we are looking at the moment to identify where those gaps are, and part of the primary care strategy is to put in place the most appropriate services so we mitigate and hopefully diminish those gaps completely, so that patients have access across the whole of Trafford to the same level of care, no matter where they are within the borough. So it's a work in progress, unfortunately, and we are at the very initial stages.
And I suppose the other point is, it's about using the data on the gaps in order to commission differently. So using the TCC as part of the commissioning tool. So it mightn't be the TCC that actually does the gaps, but the data that we get from the TCC will actually be used in the wider commissioning redesign of the services, which is part of the TCC's role in terms of wider intelligent commissioning.
Thank you very much. Sophie, please.
Thank you for your presentation. I've got a few questions. I've got 3 questions and then a request for some more information. Firstly, I think the Christmas call sounds like a great idea. What does that actually comprise of? You know, so if you phone somebody on Christmas Day and they say, I'm lonely or I'm struggling at home, would any intervention be enacted as a result of that?
Obviously, it depends on what they identify as the need. So we have access and all the information about how to refer into all of the services that will be operational on Christmas and Boxing Day. So if that's a healthcare service, they will refer those patients directly into those services. If they need a GP, we'll get a GP to come out and see those patients. If they're struggling because they're really quite depressed, we'll put them in touch with, or we'll ring on their behalf, the Samaritans or whoever's most appropriate for that patient. They have a full directory of services in the TCC available to them. So we know on every day what services are available that will support that patient, and hopefully make them feel a little bit better on that time. Even if it's like calling a family member or you know, whoever it is, somebody that they've not been in touch with, somebody that's playing on the mind that will make them feel better at that time, the TCC will take on that and hopefully get a better outcome for them.
Be interesting to hear what the outcome of
it
that
will,
is.
we've never done it before.
So hopefully we'll be able to come back and report that back to us after Christmas. And just talking about outcomes as well, so you've got a whole page of measuring benefits, cash releasing outcomes. I mean, it's perhaps too big a question really, but how do you actually measure those outcomes?
So what we do is we look at all the activities. So every patient that's enrolled within care coordination, so I'll do care coordination first, if that's okay. So we look at the patient's activity. So how many times basically they were admitted into the acute, or they access services within the wider healthcare system from the minute they were involved. We monitor them. Then also we look at their previous history, because they've given their consent. We can look at their previous data. So we look at their post 18-month data history. So we know how many admissions they would have had to hospital. And then we compare that with their current activity. So we're trying to assess whether the interventions that have taken place as part of care coordination have actually had the impact that we're hoping for, which is a reduced number of referrals into the acute or A&E attends. When it comes to referral management, how we measure the benefits is in regards to looking at the referrals going through are the appropriate referrals to go to the appropriate place. So we're making sure that if it's appropriate for them to go to secondary care, they go there. If it's appropriate to go into the community, they are redirected into the community. But also looking at the effective use of resources policies to ensure that the referrals are appropriate. So by that, we look through all the referrals, and then we actually refer back to the GP the referrals that aren't appropriate for whatever clinical reason has been determined.
Well, my next question, sorry, I'm dominating this, but it's just really fascinating, is about referrals. So self-referral is one of the routes into the service. What is the uptake of self-referral?
It's quite small at the moment.
Yeah.
I think, and you know, if to be honest, we wanted to ensure that we really had a good, effective service before we really promoted it wider to the public. It's been, you know, all the information has been available for the minimum 24 months in GP practices, so they're very aware to refer in. The number of referrals received on self-referral has generally been through word of mouth or a carer that was aware of the service that was available. But now we feel that we're in a really good position to really promote what care coordination can offer. We're going to do a much more high level campaign throughout Trafford,
so I wouldn't
they're
say
really
it's
aware.
particularly obvious in the public domain. As a member of the public, I wouldn't necessarily pick up on that.
As part of the wider, the bigger primary care strategy that we're going to do, that will be a fundamental part of that to ensure that, you know, people in Trafford are aware of it and can refer in.
And will you have a number of different routes via which, because obviously not making any assumptions, but maybe some of the people who perhaps would access it wouldn't always find a digital route the most user friendly for them. So I'm not assuming that, you know, everybody would be like that.
The majority of our contacts, especially with the clinical team, will always be over the phone. But there's obviously lots of other ways that we can, you know, we can email, we can do whatever they really need, to be honest. But we will always make sure where we can, we have the right technical solution in place to support them whatever their needs are.
Yeah, because sometimes that can be a barrier, can't it? If it's all digital. And just one other request. I think the case studies are really helpful, but I think for us as, you know, some of us are health professionals, some of us are not, but essentially we represent the public and this is a publicly held meeting. I think some really well illustrated case studies that portray patients' journeys.
So you really
and
see the journey,
outcomes,
you know, I understand,
you know, sort of, you know, from a very sort of personal point of view, really, I think are really helpful to us to understand the impact.
Thank you for that feedback. I'll make sure next time that we do.
I mean, these were good, you know, it's not criticism, but I think more, you know, maybe a bit more sort of fleshed out and even, you know, with a little bit of the service user's voice in there as well, I think would be really good for us to understand the impact of the care coordination.
We actually have tried to, we've asked a number of patients who've been enrolled on the service to actually do a video for us, you know, just to see about their own feelings and how it's gone for them, but we've not had any uptake so far. But we'll try and convince them.
So I was thinking, could we even bring a service user to this committee?
Absolutely.
But this may not be a very comfortable environment for them, you know, feel like they're being grilled by.
But maybe if we could video them for the future, that would be a good,
I think that would tell the story really well.
So certainly not now. We're being webcast. So
no.
But
oh no, yes.
Thank you.
Moving on, Denise.
Thank you for your presentation. It tells the story of an excellent model of care that you want to achieve. Actually, Sophie's asked part of my question. I had two small questions, and one was, how do people self-refer? How are they made aware of it? I mean, obviously there are some teething problems with how to be made aware of it, but what you know, have you got a good process, a simple process for self-referral?
Yeah, so literally it's a telephone call to the coordination centre. It's as simple as that. And then the clinical team ring them back, and it's open 7 days a week, 8 till 8, so people can call at any time between those parameters, and they always get a call back either within the hour or more or less in a couple of minutes.
That's good. And my second question was, I know it's probably great detail of the case studies, but and closing the gap and the loopholes, and obviously keeping trying to achieve higher standards in the way you deliver things. Who feeds into the case studies? Who run the case studies? Who direct them, and who feeds in? Is it multidisciplinary? multi-focused.
Yeah, it's a full multidisciplinary team. So everybody that's had an element of that patient's care, that's part of the case study. So we sit down in a room together and we go through patients individually and say what could have been done better, where were the lessons learned. So that's also what we do as part of the public sector reform work as well, to ensure that if we'd identified that when we get the social care feeds in, so if we'd identified there was a social need, so there was a housing issue that was causing longer term health conditions, that's when we could have coordinated that. But we all sit down together and have those reviews.
Thank you.
Thank you, Dave.
Thank you, Chair. Thanks very much for the presentation. I think it was really helpful. Clearly, it is a newish service, and it's really a follow-on from Sophie's question around the cost-benefit analysis, which is always quite difficult to carry out.
Yeah.
Is it done independent, or do you have to try and do it yourself?
We do it ourselves through our business intelligence team and finance team.
Yeah, because most from public sector reform, I understand, do it independent of the service itself.
Right.
And obviously, does any kind of cost-benefit analysis take into the equation the cost of providing the service that you are actually providing?
Well, we've seen since the inception of the care coordination specifically, there's been about 11% reduction on average of the spend in the acute admissions based on that cohort of patients. So we can see how the interventions are actually preventing people from having a readmission.
Yeah, but in terms of the service that is being provided, obviously there is a cost to that service.
Yeah.
So is that taken into the equation of any cost-benefit analysis that is done? Or is it purely just the savings that are made from the GPs?
It's the latter. So it's the savings that are made from the reduction in patients going into secondary care, and also the amount of referrals that we're receiving from GPs and directing them to the most appropriate provider. So rather than to go into secondary care, which is more expensive, they'll go into our community provision.
Yeah, I do understand that. It's just because obviously this service that you're providing wasn't there before.
Yes.
So there is a cost to that.
There is, absolutely,
service. So that surely has to be taken into account of the overall cost.
It does, yeah.
Of any cost-benefit analysis.
Yeah, absolutely, yeah.
The other thing is about the referrals themselves, just on a minor point really, around the fire service, because I know that the fire service does carry out fire safety and well-being assessments.
Yep.
And do they refer into as well?
They do, absolutely. Yeah, we refer into them.
Sorry.
I couldn't list them all individually. The list would be really long. We refer into them and they refer into us and vice versa. So because the relationship we've now established, the fire service also go back. We went into this lady today and there was we've got significant concerns, and that will then prompt a call to those patients.
Yeah. Okay.
Thank you. Steve, please.
Yeah, thank you, Chair. And at risk of asking, and Cathy for your report, and at risk of asking the same question, I'll ask it slightly differently. And it is about the growth and as you start to promote TCC. I know we've attempted this before actually, and it'll either take off or it won't it? It'll do one of two things as we move it forward. So I guess instead of asking you how do you plan to grow, I guess my question is, if the demand and it takes off, how do you plan to manage the demand that could potentially come through the door is question one. Please, and I'll just ask you my second question so I don't come back to you if that's all right. And it's a very well written report, but what I didn't see, or what wasn't clear in there, and forgive me if it is in there, is anything on a mental health pathway and how you support mental health. So I know that's one of the core objectives of the TCC, but there isn't actually a pathway in there for how we support mental health. And I wondered whether you could just maybe explain how you would support, refer and follow up with a patient with mental health difficulties at a time, and maybe just so we can understand that in a bit more detail, please.
Yep. So we just to touch on the mental health issue, if that's okay. We've got two mental health trained nurses who actually work as part of the care coordination team, and the mental health team will also be working as part alongside our colleagues in care coordination in the new year. So referrals will go directly into TCC, and we can support them both in the community and different settings. So mental health is a significant part of the agenda. So we do have a mental health capacity within the existing team already, but we're going to expand that even further so we can hopefully support in the same way we do for patients coming out of hospital with a broken leg or hip, as we can for the mental health patients that we serve as well. And in regards to your first question, so it would be for the providers to look at how they're going to use the TCC moving forward, because it basically facilitates their service, and we're only like the facilitator in the delivery of that. So that's how we're going to move forward.
Laura.
Thank you very much for that. And I too was very touched by the idea of calls at Christmas, which can be a very difficult time for people. So the figures, to me, some of them just don't seem to be clear. So on the pathways page, there's a couple of points there. One is it's blindingly obvious that you've got a massive diabetes issue. You've got 10,910 patients. So that must become, looking at it objectively, is that right?
Yes, that's right, yeah.
A massive priority to us, because especially if they're in the younger area of being diabetic, the consequences are vast for them, for us. And so that's something I think that, I know you're doing smoking cessation, but we don't have figures there. So you've got falls down at 292, winter plan 270, discharge, whatever. And then we jump to one figure on diabetes, which actually over your overall figures is blindingly high, and something I would have thought was a real area to focus on, both for children, adult care, provision there. And I think Jane mentioned it, of ways of getting that down, because as we know, or as I know, it is in fact a killer one way or another. So that I would like more information on that, and I think others would. So that was one. The other point was on the time saving element. It says GP time saved in processing referrals is 35,000 per annum, 7,300 plus hours, and then you give a figure of 80,000.
Mm-hmm.
I just don't know how that's like £10 an hour, but that is an unquantified amount, really. It isn't. If you put it in there, I would like to see more of the clarity around the calculation, because I don't think that's particularly clear. And then on the second one, patient's experience, on a survey, 86%. But that's like 1 out of 10 or 1 out of 7. It's just not it doesn't have any meat on the bone, unless I'm missing the point somewhere, which I apologise if I am. But if you want to put a figure in, I'd like to say out of 100 patients called, or we call 500 patients or 3 patients, because it doesn't really add anything to me.
Okay.
And then the final point was, are a lot of your referrals through police, or they're not stated as individual? So I know that police get a lot of calls. So do you get referrals straight through the police?
Not at the moment, but we do as part of the One Trafford response meetings that we have on a weekly basis. So that's certainly our intention moving forward as One Trafford response expands across Trafford. As part of that process, we will have direct routes in which the police can refer in. But the main issue about that is in regards to consent. So we have to get the patient's consent before they can be enrolled into the service. So we're trying to work through the logistics of those things.
Because that would certainly take a lot of pressure away from the police, because obviously that is where their time is quite significantly spent.
Yeah.
And necessarily the that's where redirection needs doing, because everybody seems to think that phoning the police is the answer to everything.
They do, absolutely,
from the lost cat to the lost child, to the to fallen out of a tree or whatever. Actually, they're not necessarily going to the right place. And finally on that, I would really like that number that you're going to give out, maybe even to counsellors first. My worry is you're actually going to be inundated once the number gets out there.
Yeah.
So I don't know if a test bed would be to give it to local counsellors, to let them trial it with you, because I have a few cases that I would have put forward myself. So it's just about clarity of the numbers that I'm interested in. But
apart from that, it's a very interesting report. But if I get you if I feed back the clarification on the numbers post the meeting tonight, that would be okay.
is that
And I'll
okay
get
with
you all the
everybody? Yeah.
definitions of how those have been calculated. And we'll make sure that hopefully that will give some clarification to the points you based.
Yeah, brilliant. Thank you very much.
Thank you. Can I just remind members, and thank you, Laura, you obviously do, just to make sure that you speak into the mics, because obviously we've got people watching. Sophie, I think you just wanted to make another brief point, then I think we must move on this subject. Thank you.
Just a really quick question. Have you got any data about the uptake of the service throughout the borough? The distribution of users from one side of the borough or one end of the borough?
It's a really good point. I know we've never actually looked into that, but we can do that quite quickly. So yeah, I'll feed that back at the same time as the other points, if that's okay. That's a good point.
Okay, thank you.
Yeah. Just on my out of interest and just to follow up to what Laura said, I'd be fascinated to know how the GP time was calculated. It does seem some slightly arbitrary figure. Not denying there must be a great deal of GP time saved, but I think we need a bit more clarity as to where some of these figures come from rather than just approx. And on another point that was mentioned earlier, I mean, I have recently been liaising with the family of a lady who is coming out of Wythenshawe with quite severe needs and has Alzheimer's, and I did refer it to Dan in one case. And there was some concern expressed, not least by the manager of the ward in the hospital, that there still seems to be some delay in making sure the appropriate care is arranged. So we still clearly have a way to go with this particular issue, but obviously this might be one of the tools to make sure it does going forward. If that's all right, ladies and gentlemen, very briefly, please, Jane. Thank you.
Just pointing out, the three of us mentioned the condition diabetes and the numbers that the 10,000 numbers. Just, I feel we might need more information on that, given that 3 councillors asked for that.
Yeah,
could we request some more information on that particular pathway?
No problem.
Alex, if we can make a note to get that and make sure Jane's notified of the outcome. Yes, absolutely.
Can I just say one word? When we think that diabetes costs £1 million a minute, that's what it's costing us.
Yeah, as I say, if that can be shared with all members as soon as we receive that, and thank you very much for that. That was a very succinct report on what's quite a complex rollout, so thank you very much.
Thank you.
Moving on to our other presentation this evening, which is item 5, which begins on page 1 of our report, which is the Community Services in General Report. I think, Sarah, you presenting this.
Thank you, Chair. I'm Sarah Radcliffe. I'm the Corporate Director of Commissioning. So that's the Integrated Commissioning Directorate across the Council and the CCG. So includes the team that you've just heard from at the CCG that leads on primary, community and secondary care, all age commissioning of social care in the Council, public health, and also performance and outcome across the health services. So tonight's presentation is about the community services programme that we're undertaking around Pennine Care. So it's to give you an overview and an update about where we're up to at this present point in time. So just a bit of background, and I'm sure quite a lot of people know this, but in terms of the services themselves, Pennine Care have been running services for around 6 years within Trafford, Trafford's footprint, but they did give notice in the autumn, around October, to actually withdraw services based on contract from Trafford itself, so not to provide community services in Trafford. Since that happened, they've also given notice on their whole footprint for community services. So they are withdrawing community services from their whole footprint, so including Bury, Rochdale and Oldham. But because we had been in discussions with them beforehand, we will be the first locality to actually put in process this programme of work. But the other 3 CCG areas will also be doing it and following on from us in terms of that. What we're hoping to do is actually the decision is based on having really quality services on the ground in Trafford and maintaining those services, and those services being stable in terms of our people and the services that are being provided both across health and social care. So it's very much about wanting to get to April next year, Q1, in terms of the model of community health and social care integrated services in Trafford with a stable provider. So the services on the ground will remain the same. The issue is about who will host them in terms of running those services for the future. There are 38 services, so it's adults and children, mainly community, but also CAM services are in there as well in terms of mental health. And obviously there's a very established programme of work that has taken place within Trafford around integration of health and social care on the ground, the butterfly model, the 4 neighbourhoods, the Section 75, all that will remain in place. So that will not change in terms of what we're looking to do. At any point, if it doesn't make sense or you need clarity, just let me know as I go through. So in terms of the actual programme of work that we've entered into, obviously it's been a programme that has been led in terms of the commissioners. So in terms of the commissioners, it's been led in terms of the Integrated Commissioner Directorate across the 2 organisations. So it's a programme that's been led. We've been trying to be very transparent about our transaction and what we're going to do in terms of how we will take this forward based on money and also our process that we've been going through. Obviously, the staff and the clinical teams are really the most important aspect, that we want to make sure that those staff are retained in that model and that actually we get to Q1 with those staff still very motivated and providing services for Trafford and Trafford people, that we are absolutely positive and backing in terms of all of that. We're trying to ensure with Pennine Care that staff are kept up to date in terms of those processes and how we take that forward between ourselves and the provider in terms of doing that. And also that what we do will be a strengthened model in terms of how Pennine Care services will actually link with the wider services within Trafford in the Local Care Alliance, which is made up of the acute services, mental health, social care, independent sector, as in the third sector, etc. And so throughout the transition, what we're really looking for is those services are resilient, so that we have resilient services in place for the people of Trafford without a break as we go forward. So the actual objectives of the programme are actually about making sure that that model is in place and it's a high quality model. So we need to build on the model as such. So it's actually sort of going forward, we build and we strengthen on it in terms of partnership working and who we work with, that it's an effective and timely transfer of those services. So we are looking at doing it, and we'll, I've got a timeline for you, but we are trying to do it in the most timely way in terms of Pennine Care and how we actually provide a preferred partner in terms of doing that, that we maintain the focus on the services throughout. So actually the programme is such that actually it's just not about sort of moving contractually, it's about working with Pennine Care to ensure that those services, as we go through the process over the next few months, retain our focus on those clinical quality and that's transition, and also that we acknowledge any cost pressures that there might be, and that will be historical cost pressures most of the time, that we actually take that through into the due diligence process as well. So in terms of the timeline that we're working to, so it's quite a tight timeline in terms of doing this. So obviously the notice was given in October and we're heading towards the new financial year of Q1, so April, to try and actually stabilise the services. So there's 5 key components of doing that. There's a gateway to each of them, so we're trying to get through each one in a specific way. So obviously the mobilisation of the whole programme, which has actually happened in terms of doing that, agreeing the scope and the procurement process for us, the scope being the full model. So we're actually looking at all the model intact, moving, so it stays within Trafford. We basically, people on the ground should see no difference in terms of what's being delivered to patients and carers, and in terms of the staff, we're hoping obviously it will be a time of great change for them, but in terms of what they deliver on the ground, the teams they're in, where they deliver it, who they actually work with, that will be no different as well. So in terms of that scope, we will then be looking at a due diligence process. So I'll go on to the timeline about how we get to a preferred provider, and then that will be a whole due diligence process. So absolutely working through about with a new provider and preferred provider, how we get to a point where we actually want to give contract to that provider through an open book way in terms of all those services and how they can provide them in the future. And then we will look to transition and implementation hopefully in Q1. But obviously that is quite a tight timeline in terms of what we're hoping to do. And in terms of how we're running it in the programme approach, so we have a community services transition board, and I'll go into who sort of sits on that, but we've already mobilised below it all those task groups, and those task groups are across commissioning and provision, so Pennine Care and commissioning across the council and the CCG, and we're looking at the whole sort of commissioning and contracting process, so those services, the 38, how we do that. The whole communication and engagement, we're trying to do as much jointly as possible between all the organisations. So there's one key message that goes out from us all. The operational delivery, so actually making sure that we continue to operate in the way that we need to do and that is actually a smooth transition. Obviously, the whole HR and workforce component. So the services will be made up of 2 groups of staff in effect. So there'll be staff that are employed under NHS contracts and there'll be staff that will be employed under social care council contracts. Those council contracts will remain the same. The issue will be, obviously, because Pennine Care were the NHS contracts, and that will be hopefully a 2P situation for staff in terms of that. Finance and estates, looking at the financial profile, but obviously where services are being provided from will also be part of that whole portfolio that we'll be looking at. And then making sure the technology and the information and governance goes through the whole process. So all of those task force groups at the bottom are also led by a senior person, either in the council or the CCG, in terms of doing all of that. Obviously linking up to the Community Services Transition Board, and then statutorily we would go to the 3 statutory organisations in terms of the CCG Board, the Council and Pennine Care Foundation Trust itself in terms of any sign-off of process. We've put there about health and scrutiny task and finish because obviously there was the phlebotomy health and task and finish group, which is one of the 38 services. So hopefully agreement from scrutiny here that would actually be across the whole programme of work now so that we can actually link to and have that relationship with scrutiny as we go forward. And then obviously our governance approach, as I've just sort of said, in terms of where we link to in terms of governance and that statutory route. I suppose the most important development that we've had is really about the membership of the transition board. So we've added membership to that now. So there will be a member of NHS England will be added to that, and also NHS Improvement. The reason for that, because the whole of the Pennine footprint is now looking to not provide community services. NHS England and Improvement are getting involved, but they're actually sitting on our board because we will be the first to do this piece of work across the footprint in terms of doing that. And that's the membership is at the bottom, and as you can see, it's basically officers of the council and the CCG. So joint role for myself across both Diane and Kathy and Nikki, and then members of Pennine Care. So they're executive members of Pennine Care, Keith Walker and Emma Tilston, and Keith Walker is the executive member across the whole of Pennine Care for this programme of work across all of the footprint. But obviously we'll be prioritising Trafford because we're going first at the moment. And then when the new preferred provider is identified, they will also sit on the board at that point. That's sort of how we're doing. Obviously, NHS England and NHSI will be added to that from the new year. And then in terms of roles and responsibilities, obviously this responsibility of the commissioner is actually to sort of hold this together and ensure that it happens, and ensure that it happens in a timely way, and that the services obviously are provided on the ground to patients with a quality aspect to them, that we go through the whole due diligence process in a sort of programme managed way, which is absolutely transparent between the partners, and that we actually respond to the regulatory organisations. And that's why NHSI and NHSA will be working along us. And we would expect and provide reasonable support to Pennine Care as we go through this process. Obviously for Pennine Care, this is a really big development for them. It is changing completely the role of their organisation. So it is a very much a relationship that we need to keep a very supportive role with them in order that we get to a point in April where we can take all these services through for Trafford. And then Pennine Care itself in terms of that, so we will be asking that they enable us to have all the insight and information for those services, that's transparent and on the table. They give appropriate information at relevant time and in terms of service provider. obviously continued support to service delivery. And one of the areas is if we got to a point by April where the services hadn't gone to a new preferred provider, Pennine Care will continue to provide those services. So at no point will there be a gap in terms of what will be doing. And also that they will continue to work on the development of the Local Care Alliance, which they've been really, really active in and actually chair at the moment, the provider board for the Local Care Alliance. They will continue to do all that system work as well as we go through. And obviously, again, with our regulatory organisations. Joint role, obviously relationship management is really, really important, particularly at this time in terms of what we do. So that whole sort of communication and engagement plan, I think it was really important that we are transparent with staff about what we're doing. We've tried to be transparent to every part of this process and not actually give expectations which weren't real, but actually be very honest about where we were and what we were doing and what we're hoping to do in terms of that. Level of collaboration is obviously really important. We have to be around the table. So in terms of relationship management and being around the table with Pennine Care and with the new provider. So it's absolutely a shared programme of work that we're doing in terms of getting to this point. And I think Pennine Care are very positive about getting their staff to a point where they will positively move to a preferred provider in terms of doing this. And then the actual sort of timeline for this and where we've started and where we've gone to. So obviously October wasn't very long ago. So we've sort of mobilised quite quickly in doing this piece of work across the organisations. So we asked for expressions of interest. We've gone for a light touch procurement process. So actually trying to be very transparent about our procurement process and what we want to do in terms of doing that. So there might be other parts of the footprint which might not be going in this way, but we felt it was a very transparent process to do a light touch procurement process. So we asked for closing expressions of interest late November, and we had quite a lot of expressions of interest. I think one of the worries from the staff that I was hearing that actually there might be no expressions of interest, but actually in terms of the model, in terms of what people saw, it was a really positive model of delivery, a really integrated model of delivery, a very forward-thinking model of delivery, really, in terms of what we have in Trafford and in terms of what the rest of GM has. I think it is a very positive and forward-looking integrated model. So there was lots of expressions of interest in terms of that. We then looked to closing date for intentions, and we've taken a handful of organisations through for invitation to tender. So asking now a set of questions which we would want to do in terms of how they would deliver services in Trafford, their knowledge of Trafford, their knowledge of delivering services for all age across mental health and physical health, adults and children, their knowledge of integration in terms of secondary care. So we've put quite a lot of questions together for that. And that actually evaluation process will start next Monday, so that we will go through an evaluation process which is led by STAR and the procurement process, but with senior members across the council and the CCG working on that to get us to Friday, where we're hoping on Friday we'll be able then to look and decide a preferred provider that we can then start to work with on the due diligence process in the new year. At this point, it will be a preferred provider, so we won't be giving contract at all. It will actually be the preferred provider that we want to work with to take us through that due diligence process, which was in the 5 parts of the mobilisation. And that's it, Chair.
Questions, please. Yeah, hang on. Super. I'll start with Steve, you indicated first.
Thank you, Chair. Thank you, Sarah, for the report. Just one question from me, please. Just on Section 4 and the membership of the Community Services Transition Board, and I'm not expressing an opinion either way, nor am I questioning any of the members of that board, but would it be appropriate to have an executive member from the council sitting on that board? And I'd just be interested to take your opinions on whether you would seem that appropriate for that board, given the impact this transition will have and could potentially have on our residents, please.
I mean, I suppose at the moment it's an officer level, and we've done scrutiny and then accountability to an executive part, both of the CCG and the council. I can certainly take it away, and we can sort of look at how we maybe can strengthen that in terms of the relationship and the work with the executive, and actually having visibility at each stage, which might be more than just the reporting process. So I can take that away and look at that in terms of that sort of link and role.
Yes, I agree. Actually, I think this is huge, and I think we need some member representation, if not necessarily at that stage of the process, maybe as we go along. Sophie, please.
Hi, thank you for the report. Yeah, I've got a number of points that I'd like to raise, actually, and just following on from Stephen's question. Membership of the board, should it not include a body such as Healthwatch that maybe represent service users? Obviously, we've got a number of different organisations or individuals represented there, but I do really feel very strongly that the voice of, well, both staff as well. I mean, in this particular footprint, the staff of Pennine Care have been stupid numerous times in the last number of years. I mean, they must feel very, very threatened and very concerned about this, I would imagine. And I really do feel that their voice should be part of this, and also a patient advocating organisation as well. Can I say thank you for the report? It's very comprehensive, and obviously we recognise, this is dealing with a sort of a very serious and issues that have sort of far-reaching sort of legal consequences. But can I just comment on the language of it? This committee is a committee which is here to represent the people, the residents of Trafford, really. When a lot of us, I sort of comment on this before, are maybe lay people, we're not commissioners ourselves. And I think that maybe, I don't know if it could be presented in a slightly more user-friendly way, and I know, every profession has its own terminology and its own jargon, and we're all guilty of using that. But I think this is a committee that is intended to be sort of public-facing, really, and just to make it a little bit more accessible, I think, really, to the sort of wider community, really. Maybe that's just me and I don't understand it, I don't know. But can I just ask, what's the history with Pennine Care then? Why is it that they want to pull out?
I mean, I don't suppose I can speak for them, but I think they feel at this point in time, in terms of their strategic direction, they don't want to be they don't want to deliver community services. They want to concentrate on mental health. So that is what has been in their public board papers, etc. They want to concentrate on mental health.
So they want to withdraw all the services, really,
for community.
Okay. And probably too early to comment about preferred partners. Can you comment on that at the moment?
So I can't comment at the moment, but as soon as we do know, the communication will go out. And I think there is. I think what members are saying is you're identifying a gap in terms of what we've looked at in the community transition programme board. So I think I can take that away, and therefore maybe communication can be more direct as well in terms of if we actually do plug that gap in terms of executive, Healthwatch, etc. So what we're aiming for is that by the 2nd of January, so when everybody comes back after Christmas, we can be clear on the preferred provider, and then that will be a public known, hopefully, organisation that we would then be able to work with.
Do you have a vision of what the service might look like?
So in terms of currently, the service will look like it does at the moment. So it will be the management of that which will change. I think one of the things that we would want to work on in the future, so post April 19, is what the service might look like in the future as well. So lots of the things that Kathy was saying and has been identified in terms of, information we might have about gaps and the way we work, about primary care, about neighbourhoods, how it links. That is a different piece of work that we would want to work with the new preferred provider in terms of that. And I take your point absolutely about language. And it might be that we need to, across my integrated commissioning directorate, we might need to sort of look about how we present. And even when we do quite detailed reports like Kathy did, maybe we put something else together which is a bit more user friendly as well, so that actually there's that, so you can have both in effect in terms of what you want to be able to use and engage with. So
okay, thank you very much. Thanks.
Dave.
Thank you, Chair, and thanks very much for the report. There's 2 points really, and it's to agree with Stephen really that in terms of the transition board, I'm absolutely convinced that there should be some member involvement on on that board. And the second point is, what consideration was given to bring the service in-house? Because it seems to me that we are sometimes floundering around for different organisations to come in and run the service, and I would have thought that there should have been serious consideration about the possibility of bringing it in-house. I mean, I don't know the background, all the background to this, but
So in terms of the actual model, the majority of staff are NHS staff. The social services staff are already employed by the council, so that will remain. In terms of the way they work together, that's under the Section 75, the two organisations, and that will remain as well. That's part of the procurement process that will go. In terms of the NHS staff, in terms of in-house, there isn't an in-house we could just move them to in terms of that. So it is actually looking to those two other providers, which will be NHS, as well as other people who might to actually say, well, where will those be? But there isn't an in-house in terms of, so the CCG or whatever couldn't actually employ, because it's a pure commissioning organisation rather than a providing organisation. Does that answer your question? In terms of in-house, were you thinking of anything specific?
Well, because what you're talking about is the management of the whole, aren't you? In a sense of the coordination and everything else. I mean, I'm not completely au fait with how